We have a lot of new users now, so you may not know Sir Winston Chee. He has a long history with TDO, and I have to say I've probably learned more from Sir Winston than maybe any other educator as far as how to look at a case, how to treatment plan, how to think outside of our very narrow focus. So he's had a very profound effect in my career in getting me to think through things. And for all those of you who don't know him, he's probably one of the finest dental educators in the country. And what's nice about him is he can argue really passionately with you and still remain your friend. And sometimes that's the hardest thing to do in dentistry, is to have these arguments and still remain the best of friends. And we've been friends for probably 20 years and argued almost continually through that time. And it's been one of the enriching experiences of my life. So I'm very honored that he's agreed to come and talk to us again about zirconia, which we all hate and he loves. So he's going to try and make the case for zirconia. I doubt that he can make it, but he's going to give it his best shot. So please give a warm welcome to Sir Winston Chee.
Okay, thank you, Gary. As most of you know, Gary and I don't agree on almost anything. Except the one thing we do agree on, if you look at these two pictures, was long ago when we used to play squash against each other. And the other picture is from last month at our study club meeting. And he's agreed that we both look much worse now than many years ago. So anyway, Gary, thanks for having me here and with the TDO. For those of you who don't know this, Gary is part of my faculty at USC, where I direct the advanced program, and he has been a resource for us, especially I think all of you have gone down into the dungeon at his house and looked at all his toys, so he gives us some support there when we need it. And then how Gary benefits is every time I see the librarian, she asks me, who is this person? He's downloading like articles that nobody else is even looking at. So I don't know how many of you know this, but he's a mad scientist masquerading as an endodontist. So he's not an endodontist. Anyway, so he asked me he said there's a lot of hate mail on TDO chat about zirconia, so he asked me to come talk about it. So I'm going to try and introduce zirconia as a material. And then he sent me a list of questions that came from off the chat list? Off the TDO chat, and then I'll try to answer some of those questions. And if we have to deviate somewhere, I'm happy to do that if we have time. I have a laptop here, so I can jump around and pull up anything that you think is worth talking about. So anyway, but you know, TDO is this tech company and this tech stuff, so I just have a video for some of you for entertainment. So, oops, let me back up again. Back up and play.
Making smoothie.
Calendar.
No meetings today. Remember, dentist at 9:30.
Fire off.
Fire off.
Open door.
Door open.
And we're going to do one more.
Alright. Open door.
Wrong voice command.
Open door.
Wrong voice command.
Open. Open door.
Repeat that.
Open door.
I didn't understand that.
Hey! Open door!
Play on the floor.
Open the door! Open the door! Open the door! Hey, with a rock. Open door.
Okay, anyway. So, why do prosthodontists love zirconia but endodontists hate zirconia? Well, this is one of the things that happens, and that's why I have these arguments with Gary all the time. All the time, and I always ask him, you know, what about the outcome? What about the outcome? Because he likes to show me all these gorgeous radiographs with minimal openings and how he's preserving tooth structure, being a good boy, but I say, you know, but you need to know that there's an outcome, and we have to deal with it in the aftermath. So we used to use metal ceramics for these restorations. What you're looking up there are some implant-supported restorations. And because there's no periodontal ligament and it's so harsh, we get this breakage. And it's one of the most expensive kinds of problems to take care of. And we see that all the time. So when we use zirconia, it actually helps to mitigate that because the material is so durable, and also the design of the restorations is difficult, where I'll show you. But what I don't understand is, actually I told a couple of the presenters up here that, you know, you guys do such nice endo, you need to move into a better neighborhood of dentists. Is to look at the dentists they work with. And hate to say this, but I always speak my mind, they're not the best. So you do this class A endo and you have a class C dentist supporting you, so, which is too bad because most of us don't use zirconia all the time. So the primary material we use for restorations is actually lithium disilicate. So we can get patients like this today. This is a patient with severe fluorosis, and you can see there's not much tooth structure left. And so, you know, we can do things very conservatively now. We can increase the vertical dimension a little bit, like you see here. And in the mandibular posterior, we can just place some implants to restore the posterior occlusion. This is just a wax-up rendition. And then we can actually just try that on in the mouth because it's all additive. So this is just a silicone putty matrix, and then we just squash on some of this provisional material, the bisacryl stuff, and then patient can see whether they like what they see, and if they like what they see, then that'll be our treatment plan. So you can see it makes quite a difference. And then from there we go ahead and create these restorations. This is lithium disilicate. It's not zirconia. First of all, it doesn't look like shit, and you can reliably bond it. You can reliably bond it. That's the key thing. And when you do that, you can gain strength underneath it. So all of you who hate zirconia, just get one of my residents out there, and they can present to your community, and they'll convert everybody to this material, and then maybe you'll see less of the problems that you think you're seeing. But anyway, so this is the before and after. This is the before and after, and believe it or not, these things are on well enough, especially when you have residual enamel, that they're pretty predictable. So our philosophy of treatment has changed now, where we used to want really durable and the strongest restorations in the world. When we're dealing with teeth now, we rather put these types of restorations on that, maybe the bonding can fail, maybe the restoration can fail, but the tooth will survive. So we are kind of weird the way we approach cases. I mean, one of these days we can actually talk about treatment planning. So when we're very conservative as far as teeth goes, but the moment we begin to place implants, and the etiology of the breakdown is not something like fluorosis, but rampant caries or something, is a different story. We start aggressively removing teeth. But on teeth, most of the time we are not using zirconia. That's why I'm actually a little surprised to see all those zirconia restorations that were in the previous presentations. So you can get really good results aesthetically by being very conservative and not causing all these other issues that you're showing up there, right? So this is a before and after. So this is something that's pretty routine that we do. So when do we like zirconia? So this is an example when we actually like zirconia. This is a single tooth. The patient lost the tooth. And so we replaced it with an implant, as you can see. You can also see the implant is now facially proclined, right? So, and those of you who know me know that I have a deep hatred of cemented implant restorations because it's not good for you. It's not good for the patient. It shouldn't be done. Can I be more clear? But anyway, there are so many disadvantages. I can spend 2 days telling you what all the disadvantages are, and it's supported by literature with no statistics. No statistics. Okay, so here you see this, and today, guess what? We can actually bend the screw channel, so there's no reason for that, and we can do that with the CAD-CAM, some software, and some of these components. You can see we can put a scan body on there, which is basically electronic impression coping. And here are just some diagrammatic views of what we're going to do. We can actually have these abutments in here. We call them titanium bases or tie bases. This zirconia substructure is luted to the tie base. I'll tell you why that is in a while. And then the screw will drop in there, goes in here, and then this screwdriver will actually fit, and I can actually drive the screw in at an angle. So we are making more and more of our zirconia restorations like that. What I will tell you is that 5 years ago, maybe 10% of our restorations were delivered this way. But in our grad program, probably 85% of the restorations are delivered with zirconia-based restorations now on implants. Okay, so on teeth is usually Emax or gold, but on implants is almost always zirconia, right? So here's just a short video to show you how that works. This is outside the mouth before it's placed, and what you can see is that that's the axis of the implant, and this is the driver. You can see that it's what they call a hexalobular head. Basically, it looks like the number 8 round. And you can go in at an angle and fasten the implant. So the implant goes in that way. The screw channel and everything is in the algorithm of the software, so is built in there. It's actually not difficult at all. So, and this particular material lends itself very well to doing this. So here you can see it tighten up in there, and you can torque that thing to whatever requirement you need to do, right? And so this is the intraoral of the restoration. You can see what it looks like in there, and then this is the restoration that you can see. And it's it's not perfect, but it's a pretty good replacement for a missing tooth. So and then I'll show you some other reasons why we like zirconia. So it's also been shown by cell culture and all those other things that zirconia against the soft tissue is very, very biocompatible. So we have all this submucosal component up here, and so we know that you get less inflammation. There's better chance for long junctional epithelium to attach to it, and all those good things for zirconia. So there are many reasons why we like it, and then I'm learning why you hate it. So, so there you are. I think we can get a fairly decent aesthetics, and so that's why we like working with it. So here's another example. This is someone that this one was from the program that was treated while residents just finished this patient, and you can see the breakage that's happening right there. That is within a month of delivering this reconstruction. So this is somebody that paid $40,000, $50,000 in a university and then has broken teeth right after that. And that's a problem, right? Patient's not happy. And part of the reason for that is you can see in the old days we used to do these metal frameworks, and then you have to leave this space here, this unsupported porcelain here, and that is just very prone to breakage. And as I told you, we have no periodontal ligament now, and these are implants. They're basically ankylosed. So there's a lot of force on these things, and impact. And so it's a problem, and you get this issue with breakage, okay? So that brings me to tell you a little bit about zirconia. I don't know how much you heard about it, but this is some very basic stuff. This stuff occurs in several allotropes, right? Several allotropes. So same molecular stuff, is just the crystalline lattice that's different. So this tetragonal form, that's what you're looking at, and this is the form that all of you hate to grind through. It's really strong, it's really hard, and it's basically looks like this. This is the crystalline form. And then there's the monoclinic form, which is looks like this prism and has reduced mechanical properties. But this is the stable form at room temperature. Room temperature. So we have to force this into becoming this in order for us to use it for dental purposes, right? So what does that mean? So what that means is that when you make the restoration or you mill the restoration, you mill it in the monoclinic form. You mill it in the monoclinic form. So you get it where you want. You send this. Does everybody know what an STL file is? It's just a three-dimensional thing. STL is standard tessellation language. It's just you get this three-dimensional file, and you tell the computer, or you tell the milling machine, or you tell the printer, as Pushback was doing, I want you to make this thing in 3 dimensions, and you make the thing in three dimensions. And then the STL file, you can mill this, and usually, if you had a milling machine, which cost maybe $500,000, and the burrs, every time you change them, cost maybe $600, would you rather mill it in the monoclinic form or tetragonal form? Understanding that your machine and your burrs have wear and tear. You'd obviously want to mill it in the monoclinic form, right? So it's softer, it's less wear and tear in your machine. But here's the catch. The monoclinic form is 22 to 25% bigger than the tetragonal form. So what happens is you send the STL file, and then the STL file has to be expanded in 3 dimensions by 25%, and then you mill it, and then you put it in this oven that we call a sintering oven, and you shrink it back to the original size that you wanted, right? And what you have to understand is that it is impossible to compensate for that distortion in 3 dimensions. That means your crown will not be the same as what your STL file said it's supposed to be. And anybody that tells you different is either stupid, a liar, or a fool. Okay? So what does that mean? What that means is, for a crown, maybe you can get away with it, but when you go to the multi-unit restorations, of which I saw many up on the screen by Charles and Pushback, that distortion is significantly off, right? And so that's why I say we don't like to use zirconia on teeth, but we have a way to compensate for it when we do use implants. Okay, so just keep that in mind. Just keep that in mind. So there's this issue of that happening, right? So just understand, you mill it in this form, it's bigger, and you force it to shrink back to the original form, which is this form. It's called this tetragonal form. So the next thing you have to understand is, if you remember your physics, if you force this allotropic change, if you apply any energy to it, like heat, or you are drilling, you're cutting a hole in the crown, right, like all of you are doing, then what you're doing, and why the material is so strong, is you are applying energy. The energy causes an allotropic change. So you're now going for tetragonal to monolithic, right? You understand? So when you're drilling, or I'm adjusting occlusion, I am weakening the restoration. I'm weakening the restoration. So here's just a diagrammatic show of it. And so here's the restoration, and what happens, and this is what you call transformation toughening. That's what makes zirconia resistant to fracture. And all of you in this room, most of you probably hated dental materials, except for Rick Schwartz. Hated dental materials, right? When you were in dental school? Don't lie to me. So, the fracture resistance and toughness is not the same as hard and soft. So your car tire is tough, it's fracture resistant. So when you say that zirconia is harder than feldspathic porcelain, it's not the case. It's just fracture resistant because of this, this property. So now what happens is you apply energy to it and you try and fracture it like this. What happens is you then force it, or you don't force it, but you apply energy, it goes back to its stable form at room temperature, so it becomes monoclinic. So that means it expands by the 22 to 25%, and it pinches off the crack. And that's how it prevents crack propagation. So all ceramics fail by crack propagation. So this is the mechanism that prevents fractures from propagating in zirconia. Okay, so let me, and so everybody got that? Is there any, I made that sound as easy as I could. Any energy, drilling, just the force of the drill. Because you're putting a lot of force in there when you put the, when you drill into it with high. No, it's not just the heat. Any energy you put into it. Any energy you put into it. So water spray does not make a difference. It might mitigate it, but it still causes a problem. Okay, so basically you are inducing a crack by cutting a hole in it, but then all around it you are weakening the restoration. Right, you're weakening the restoration. Same difference. You're also causing a problem. So when we make these restorations, we always make one arch at a time, so the error is half. So if you're, and then we very often put zirconia if we're doing full arch restorations when the patient is going to lose all his teeth. We often put zirconia on the maxilla and a titanium bar layered with acrylic on the mandible. So any occlusal adjustments, we don't touch the zirconia. We don't touch the zirconia. And if you're delivering single restorations, unless the lead is really awful, right? And we actually tell, I tell people, adjust the opposing occlusion if it's not zirconia. I mean, it shouldn't be by much, right? So if you put in mylar, if a patient bites on the restoration and it's high, then you should fold it up and 2 or 3 sheets of mylar on the adjacent tooth, and if it's loose, as long as it's not by 2 or 3 sheets of mylar, you're in the ballpark, you can adjust. I mean, that's like 33 micron or something. You know, each layer of mylar is about 11 micron. So it shouldn't be that much, but some of your dentists are using the $35 labs. I mean, then all bets are off because they don't care and they don't know what they're doing. They just send you something white and you're supposed to cement it in the mouth. So there is a difference, I mean, and there is a learning curve. And for the most part, my message today is that it's not the material, it's how its material is used. Okay, because if you look at what I'm showing you here, it's much more disruptive than a zirconia crown on a tooth. We are putting zirconia restoration on implants. That's way more disruptive than some of the things you're doing as far as trauma to the opposing occlusion, right? Because there's no periodontal ligament and you're putting this really hard material on top of it, right? So anyway, just look at this. It's a little bit of a representation again of what happens with transformation toughening. So that bar there is supposed to be zirconia, and then you'll see a close-up. We borrowed Gary's microscope to take these pictures. And then you'll see that it'll show you a depiction of the zirconia in the tetragonal form that we like. And then you'll see the crack induced, and then it'll just show you what happens when it immediately gets transformed to the monoclinic. And the crack doesn't get smaller, but it just stops propagating. So the energy is applied, and then you see what they call the transformation change to monoclinic. And because the volume is bigger, it then pinches off the crack. And that happens, and that's the process of transformation toughening. Okay? All right. It doesn't transfer back. It just stays monoclinic. So that area of the crown, even though the crack is not propagated, is weaker because it's now in the monoclinic form. Okay? And not only that, there's an unknown, which is why I'm glad at the end of my career, because I'm putting hundreds and thousands of restorations into our patients, that there's something called low temperature degradation, which means if you take a chunk of zirconia and leave it on the table, it will slowly transform back to the most stable form, which is the monoclinic form. And how quickly that happens, nobody knows yet. But I'll be out of there. It's not my problem. It's not my problem, okay? But we've done artificial aging and all those. I'm just kidding. I've done artificial aging and all those things on them, and they seem to be holding up pretty well. So we actually mechanically test them, we artificially age them, and we test them again, and I think they should hold up for a little while more. Okay? So anyway, this is a continuation of the patient that we treated. We make a provisional restoration. We make sure everything is okay. And then I just want to show you why we like these things. If you remember the metal ceramic cutback we had before, now because this thing is not a metallic color, but is kind of white and a tooth color, we actually do a minimal cutback. So you see that? It's just a minimal cutback. And then we lay it with porcelain. So all the occluding surfaces and everything else are in zirconia. So they have less chance of breakage. And then highly polished zirconia is smoother than porcelain is. So it's actually kinder to the opposing occlusion as far as friction goes. Right, as far as friction goes. And if you look at the cutback is really minimal. It's got nothing to do with the metal ceramic cutback. So what that also means is that a lot of the, if you grade your technicians A, B, C, D, and the A-class technicians are all prima donnas. With this technology, the B and C-class technicians can approach the A-class technicians now because there's less of their skill needed to stack the porcelain on these things because it's minimal. And so labor is less, and manufacturing these types of restorations is becoming less expensive. So I'm giving you all the reasons why, whether you like it or not, this is going to become bigger and bigger, okay? And it's going to replace all the metallic restorations out there, okay? So here's the difference in the cutback that you can see. This is a metal ceramic cutback. You can see all that porcelain that the technicians had to build up, and now all we have is on the facial. You can see that little bit there, and all the occlusion is on the zirconian. Right? So here's how we compensate for it. So we make sure that our casts are accurate. There's a way that we proof the cast to make sure that it's the same as the mouth. And then in these restorations, there's actually a space built up into these restorations as they're milled. And then we lute these cylinders into it on the cast. And that's also how we compensate for the distortion with these large full arch restorations. So our fit surface will because we are cementing it on our cast that has been proved to be the same as the mouth. So the fit surfaces will fit really well, and so that's how we compensate for it. But you can't do this with teeth. You cannot do this with teeth. So in the old days, if you remember, if you did a metal ceramic restoration, you can cut and you can solder the framework if one abutment relative to the other did not fit. You can't do that with zirconia now. So I don't know how people are dealing with that out there, because that's certainly something we would not recommend. So anything beyond a single unit, I don't think will actually fit really well. So I don't know the issue with what's happening with your restorations. I don't know whether it's just occlusion or it just could be leakage, because those things are fitting so poorly. So you drilling a hole in there and doing your nice endo might not be a service. You just cut the thing off and break it and make a new one. No, I'm not kidding. I'm not kidding. I'm not kidding. Why do I say that? Because when they mail these things, you type a letter, right? It's in your file, right? You put a folder. You know, like, I hate this patient, so I have this dismissal file for the patient. Like, don't come back to my practice anymore. So you keep that in a folder, right? If you want to print another one, you can just pull it out and change the name. I hate you also, so don't come back to my practice, right? So the STL files are kept. So when they want to order another crown, they don't need a new impression or anything else. If the lab knows what they're doing, say Mrs. Jones, tooth number 3, and then just print another crown and they send it to your office. So I don't know what the big deal is. And if they're using the $35 lab, it's only another $35. So, no, I'm serious. I'm serious. So, so we store all these STL files. So if there's ever any problem, it's just printing another one out. And I would guess that from the restorations I saw on the screen, that most of them are what we call monolithic, meaning they're not layered with any porcelain. So maybe those are $25 crowns. Okay, so so anyway, this was actually published in one of the journals. This is the resident that did the case, and it worked out very well. So they look nice. They're biocompatible. They fit the implants. So by the way, I don't have any financial deal with zirconia. I don't have any conflicts of interest, but I am looking actively for a good one. So here's another example before I start asking patients. This is a patient that I treated in my practice, just to show you how things go. It was a very difficult patient. She was transitioning from having a periodontal disease generalized to implant-supported restorations, and so there were episodes of implant failure, and then we had to go back in there and redo things because there was very little bone after all the problems that she had. And so here you can see these are the abutments that I'm talking about, or what we call titanium bases. And then these are we're milling provisionals here. And then you can see on the screen, after we attach these scan bodies to those abutments, that we can actually design them. And this is a screen capture or image of my provisionals in a mouth. You can see that after they've been cut apart and repaired a bunch of times, they don't look very good. You can then kind of use them as a guideline and pull out from the library on the computer the kind of teeth that you like. So again, go back to your referrals and tell them, tell your lab to ask for light occlusal contact, because you can actually choose and you can just click a button on the computer, right? Like TDO, Gary, you told me, if the patients that you hate, there's 1 star and the price goes up 30%, right? And 2 stars is 60%. So you just click that star, and then when you're making these restorations, is the same. They can just order a lighter occlusion, right? They can order flatter cusp. It's all in the library. They just maybe they don't know or they don't tell the lab. They can do whatever they want, right? So you can have you have that, and then you have these restorations. They look a lot nicer than my provisional that was beaten up a bunch of times. And if you look carefully on this screen capture, you can see the path here that we are able to bend the screw channel, so we can peel away the cast, and then you can see this is the screw channels that are altered. And so this is the provisional restoration, maxilla mandible. And then we deliver these things to the patient. You can see on my provisional, before I milled them, this was the provisional transitioning from teeth to implants. The screw access was coming out the front, and then we can correct that with just this with this technology that we have today. I mean, it's really amazing. And then you try that in, and it doesn't look perfect, but you have to understand that this patient lost bone up to almost the apices of her teeth, and they were all waving in the wind, so we transitioned her into this full mouth implants. And then when that works, guess what? You just change the puck out. This is the puck from acrylic to zirconia. and you do a cutback on it because we're going to layer this with porcelain. These are the metallic stains that we're putting on while we're going to sinter it. That means we throw it in the oven. This is, remember, 25% bigger than what we want, right? And so in the sintering oven, we force the allotropic change. And so then you get this looking like this. The zirconia is not just one color because we characterized it before we put it to force the allotropic change in the sintering oven. Then we layer it. And then you just, you can see the change in the screw channel directions. Then all you do is you unscrew the provisional and you screw the definitive restoration in there because they're exact copies of each other, except one is one material and one is the other. You also have this STL file. If there's ever a breakage on this thing, the patient will call you. You call the lab. Either you mill another zirconia restoration or you mill the provisional restoration. The patient comes in, is screw retained, you unscrew it and put the other one in. So life is very simple now, right? Life is much simpler now. And then this is our patient, right? So I think, and I don't know, I think zirconia really has a good place for implants. So I don't myself use it very much for teeth, but there are situations when I do. So I don't know whether Gary remembers this patient. I will not mention any names, but Gary referred this patient to me many years ago, maybe more than 15 years ago. She was, she's an MD. She was a patient. She actually lives closer to San Diego than where I am, where my practice is in Glendale. She went to see, I don't know what you call them, dentists who love to do unnecessary treatment. She spent a couple of $100,000. She had soft tissue grafts, full mouth implants, and I don't know whether Gary remembers, but her teeth were not touching. Do you remember? So she was touching only on one tooth. So it took me a while to get her calmed down and get everything together. But since then, she's been a patient of mine. And what I want to draw your notice to is these couple of teeth here, where she's had full coverage restorations and some endodontically treated teeth underneath. And because she has such a high smile line, I actually didn't want to do, I tend to be pretty conservative unless there's dental disease. So this was just for aesthetics. And I told her, you know, as a joke, whenever they ask me they want to change, I said, are you looking for a boyfriend or getting a divorce? And she said, no. Then I said, then why do you want to change any of these restorations? And she said, oh, no, my husband is beginning to complain. So I said, okay. So I said, okay, let's just change this one because it looks really bad. And then she started bargaining with me and she says, no, I want to change both of these restorations. So we did, and when you remove the restorations, because they were endodontically treated, they turn some black for some reason. I actually don't know the reason. Gary, is it? Yeah. Well, you guys don't want to own up to it, so you don't remember. That's pretty cool, Gary. Very slick. Very slick. But anyway, so you see that. So when you have this, you can't use Emax because Emax is translucent. So you have to block the color. So this is a provisional. This is a provisional. I want to make sure that she's satisfied. And then from there, I went on and put the zirconia-based restoration, which was layered. And you have to put the zirconia on, and it's pretty opaque. And then we did layer it. You can see that there's a little opacity here, but it does a good job hiding this area, and then the light transmission is also pretty good. So you see this area is not that discolored either. So the patient is happy, right? But here's what I do want to show you. This is the condition of the teeth. So Gary, I don't extract every tooth with the endo, okay? He's accused me of that, by the way. So and also there's a lesion there, and I just tell her she's asymptomatic. So every year we take a radiograph. I just wanted to show you the radiographs, right? And the radiograph year after year after year and after year. And even with the zirconia restorations in there, the tooth don't blow up just because you put zirconia on the teeth, which is what I was reading on some of the chats that Gary was giving me. So I mean, I don't think this tooth is too healthy. It may be in what I call a balance, a chronic stage, but to remove that tooth would be disfiguring for the patient, and the lesion is not getting any bigger. So I'm going to leave it there, right? So the thing is, I can dig up more of these things, and I will. But and this is the question, right? I'm going to start answering questions. I'm sure there'll be more. Does zirconia opposing zirconia have the potential to traumatize the PDL over time? I mean, well, the answer is yes, if it's in hyperocclusion. But if it's not in hyperocclusion, why would it? Why would it? And does it wear at a different rate than opposing teeth? Maybe. Maybe it does. And if adjacent teeth wear and zirconia does not, is that a concern for hyperocclusion? Well, this is something that I've been looking at ever since I was a grad student. It's non-carious tooth loss. And you don't see these problems on patients with non-carious tooth loss because they have non-carious tooth loss here, but they don't on here where they have full coverage restorations. But you don't see endodontic teeth starting to blow up. They're wearing at different rates. I mean, so you see that all the time, right? So why is zirconia so disruptive? Why is zirconia itself so disruptive? So I just don't understand that. I don't see it. But this issue in non-carious tooth loss is a big deal. Yes, sir.
I think part of the discussion had to do with teeth blowing up before they had endo, as a result of forces transmitted to the teeth.
Okay, so the teeth blowing up before endo, it may be that these guys haven't thinking of the all ceramic preparations of long ago, where instead of taking less off the tooth, they're taking more off the tooth. So they may be preparing a little bit too heavily, number one. And number two, most of them, for some reason, are using resin cements, which leak. You can't bond to zirconia, so it leaks even more. And so I think that may be the reason, and not because of the material, if they're looking at that. So if you cement or I cement a restoration, and the patient has pain, the first question I always ask them, if they come back complaining of pain, I say, when do you feel pain? Is it painful all the time? No. Is it painful when you bite? Yes. Is it painful when you bite or when you release? That's the key question. If they say release is leaking, and what's the only solution? Cut the crown off, because there's a problem with cementation. So they don't do that, they ignore it, and suddenly they say, oh, now it feels better. Guess what? The pulp died already. It's just on its way to hurting. So they stall. I hate to say this, but that is what happens out there in the real world, and then you are dealing with the aftermath. Yes?
So what's your preferred cementation?
If I'm using a zirconia restoration, I just use whatever I use for my metal ceramic restoration, which is usually a resin ionomer cement. Because you don't need it to strengthen the crown. Most of the time when we use resin cements, it's not just to hold the restoration onto the tooth. It is to bond the restoration to the underlying tooth structure, because as I said, all ceramics fail by crack propagation. So when you bond it to the underlying tooth structure, you get the support of the underlying tooth structure. That's just like putting porcelain on a metal backing, like a PFM. That's why you do it, because you are preventing crack propagation. The metal itself doesn't magically strengthen the porcelain. The only guy who's not asleep now is Rick Schwartz. Everybody is... Okay, so... Rick, disagree anytime. Anytime. Okay, so... I don't know. Does that answer that question? Because I'm moving on to the next question. Yes?
Are occlusal interferences less forgiving with zirconia? Because the zirconia won't wear, so...
Okay. Dr. Terry Tanaka is not here, and I was trained as a nephrologist, right? So if you look in the literature, actually I was just at the Academy of Osseointegration, and my topic was the influence of occlusion or occlusal schemes on the survival of implants. And then I had a blank screen up there and said, this is all the literature showing there's evidence that it's a problem. Because there is no evidence. And I would say the same for teeth. So if you have an occlusal interference or let's say a balancing interference, and it is, how shall I say, is causing a lot of lateral forces on the tooth, then it could be a problem as far as causing mobility, right? Can cause mobility. But mobility, believe it or not, is a physiological response that the tooth has. So increased mobility is not a problem. Increasing mobility is a problem, right? So if you have no attachment loss, meaning you probe and there's no attachment loss but the tooth is loose, if you don't feel like adjusting the occlusion, don't adjust the occlusion. And if you feel like adjusting the occlusion so the tooth firms up, go ahead and adjust the occlusion. But that's just, so the periodontal ligament is an amazing thing, is that it compensates for all that stuff, which is why I'm showing you this picture, that we have many, many instances of differential wear in non-carious tooth loss. And this is, how should I say, under-recognized disease. You see this in your we see this in our patients all the time. We see this in our patients all the time, non-carious tooth loss. Okay? Can I move on to the next question? We can always come back if you want to fight some more. Okay? So what is the best method to drill through zirconia crowns? And if you look at this thing, they look at different burrs, and then there's another article in here, this one, which looked at, that's the same article, it looked at this burr. I don't want to pimp for any company. So what I'll tell you is that almost all of them work. One of them here didn't work. And then in this article, it basically looked at the cutting efficiency. So what I would say is, these articles will tell you that there's so much force put on these things that you need burrs developed by these whatever burr company use with a very strong binder for the abrasive to the burr you use, right? So ask them, you know, what's a different binder that you use? And the coarser the burr, the faster you cut through the crown. But just remember this, the coarser the burr, the faster you cut through the crown, the more energy you're applying to the crown, the more transformation you're causing to monoclinic form, and the more you're weakening the crown. Which is why I say, I'm not kidding when I say, just tell them to replace the crown. Just cut it off, or cut it off if there's anything in your way. Don't spend too much time trying to salvage the crown. You have a question?
About the comment of weakening the crown, since there's not the risk of fracture that you would have with other porcelains, what is the actual mode of failure when you say weakening that zirconia crown?
It's just that more of the crown now is of the monolithic allotrope, and less of it is the tetrahedral shape that you want. And so the crown itself is weakened. But then the next question is, can you bond? Because the next question is, can you seal those things? And it's questionable whether you can.
But what's the downside of it being weakened in that area? If it doesn't fracture, then what's the mode of failure due to that weakening?
That I can't answer for you. All I can tell you that there's a higher chance for that crown to break going down the line, right? It's just a higher chance that it'll break. That's all. I mean, I couldn't tell you. I don't have enough information, and certainly I don't have enough of my own information because, as I said, I actually don't like using these zirconia restorations. And I would say that many practices now are not making full coverage restorations unless they're replacing a crown that was already on there. And so when they're not using full coverage restorations, they're probably using lithium disilicate because they can bond it to the underlying tooth structure. Okay? So can we bond well enough to make a difference? Okay, so the answer is yes and no. There is, most people say you can't, but there is a guy called Matthias Kern, K-E-R-N. If you want to look, he has written a book and published many articles on bonding Maryland bridges onto teeth with zirconia framework. So the way he does it is he treats the tooth the zirconia cannot be etched because there are no different phases in there to etch. So he does air abrasion and is very well controlled, as you can see up there. 25 micron at only 25 to 35 psi. And then if you put that in a patient's mouth, you have to use Ivoclean because it attracts all the proteins and stuff from the saliva. So if you don't clean that off, you can't bond it anyway. And then you have to use a MDP containing some kind of bonding agent that does that. The most common one out there, the oldest one out there is Panavia, but the patent is off MDP, so everybody has one now. So, you can try using that. I don't know what success you're going to have to seal off that restoration again, but Panavia is so expensive, it's still may be cheaper to order a $35 crown. So, okay, so Ivoclean is basically alkaline suspension of this oxide in water, and then it allows you to attract all the contaminants and absorb them, and it has been shown to improve adhesion of all these ceramic things. So you got to go get a bottle of this stuff, but be careful when you use it. So you have to apply that. So I don't know the answer to whether you can predictably seal up those holes. So Rick, are you doing anything to them, air abrading and trying to seal them?
Yeah, and
Ivoclean.
yeah, and some sort of ceramic primer.
Yeah. There has to be MDP though. You have to have MDP on it. And make sure that they're compatible. But so right there, you're spending $20 on dental materials. So I'm just not sure is worth it. So this one, my observations, I'm adjusting 2 to 3 crowns a week. Patient comes in the ache, biting, recent crown, check the occlusion, and so on. So probably, the occlusion is high. They're not instructing the lab what to do, or there may be some leakage on the crown. So always check with Airstream and figure out whether that's a problem. And basically, that's my conclusion. It's the dentist, it's not the material. Because we do use the material, we don't use it as routinely as maybe some of your referrals are using it, but we really are not seeing that huge a problem with it. Okay, so are teeth opposing zirconia being pounded to death at a higher rate than teeth in similar situations? Well, for that, I think I already alluded to it. I have plenty of these radiographs with implant-supported restorations opposing endodontically treated teeth because I've been dealing with implants for so long. This one actually happens to be on a friend of mine that I grew up playing squash with. I've known him for years. And I can promise you that the restorations on top of implants, as far as trauma to the opposing tooth goes, is much worse than a zirconia crown. So I think it's just a matter of how the crown is adjusted, how the restoration is adjusted. They may not be spending enough time adjusting the restoration, or they may actually be unfamiliar with how hard it is to actually shave off stuff from the zirconia crowns. But I can show you many restorations like this, and again, full arch restorations with opposing endodontically treated teeth. But I mean, I can go on and on, but I can tell you that the occlusion against something that doesn't give is when the thing that you want to blame are implants, not zirconia, not the restoration. Yes?
Dr. Chee, it looks like too those teeth might be necrotic anyway.
Necrotic. I love it when you can tell that from a panorex. I really think you've got great diagnostic skills. Yeah, I really think you have great diagnostic skills to look at a panorex. So I don't know, maybe they are, maybe they aren't, but guess what? They're asymptomatic. So I'm a believer in functional retention in the new endo literature. Okay, you're offended. Don't be offended. I'm just joking. So yeah, no, I don't know. I mean, what I can say is I don't know. But really, if you have periodontal ligament compared to ankylosed implant, there is just way more trauma that the ankylosed implant is causing, and I think we just don't see it. I mean, Gary here knows what I'll be doing if that's something I saw. I'd be extracting the opposing teeth, including the teeth on the same arch. But but it just we just don't see it, right? So with that, are there any other questions? I am happy to disagree. Yes, sir.
I'm not going to ask you to disagree, just a question. I've had some referrals sending patients and they have lithium disilicate crowns, particularly on lower second molars, and the crowns themselves are fracturing.
Yes. Yes.
In those situations, do you recommend or prefer zirconium? Or
No, I prefer gold. 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 Yeah, you know, if they are, here's the answer. If they are full coverage restorations, right? I mean, just go ahead and put a gold crown on it. If patients refuse to put a gold crown on it, then go ahead and put a zirconia coverage restoration on it. There's good evidence that you can have just a 0.7 millimeter reduction for zirconia restorations, monolithic, unlayered. So you don't have to go ahead and put those 1.5 millimeter chamfers circumferentially around the tooth and take 2 millimeters off the top anymore. And so the more conservative you are, the better. But if the other thing is that you need to ask them what they cemented whether they could isolate and what they cemented the lithium disilicate restorations with. Because in our experience, if you looked at some of the cases the case I showed you, and I have many others, we are actually with like a 2 or 3 millimeter tooth stump, we are bonding these lithium disilicate restorations on top of them. And with that thickness, they're pretty strong. And then the adhesion to lithium disilicate, because you can etch lithium disilicate very predictably with hydrofluoric acid, you get a very predictable etch pattern. The only remaining issue is, can you isolate the tooth and bond it well enough? If you can, I would actually try another lithium disilicate restoration, but they have to know what they're doing when they're bonding and whether they can isolate it. Yes.
Do you have any suggestions for us down this drilling access cavities with the occlusal of zirconium crowns, fine diamonds, coarse?
No. The coarser, the faster. Fine diamonds are not going to help you. You just have to buy something from some company that sells the diamonds. The only thing they have, it has to be very well bound to the shank, so they have different binders that they're putting on there. And the coarser the grit, the faster you go through them. I mean, using fine diamonds and all doesn't help you. It's just going to take you longer. You burn up more burrs, generate more heat, and it's more of a problem. Yeah.
Okay, when you etch the lithium disilicate, what concentration for how long?
7% hydrofluoric acid for 20 seconds. No longer than that, 20 seconds. And then after that, here's the key. After that, you either have to ultrasonic the stuff with alcohol for about 5-10 minutes with alcohol to get rid of the debris, or you can just put the phosphoric acid, the stuff you use to etch in the mouth, on it for about 30 seconds and then rinse it off. So I usually just use the phosphoric acid. So the people who are cementing these restorations, they need to know those protocols also. Unfortunately, a lot of them don't follow those protocols. But if you follow those protocols, it's really quite predictable. So, I mean, if I showed you because we treat a lot of these patients with non-carious tooth loss, the stuff we're doing with just additive restorations or bonding these restorations on, the magnitude of the volume of the stuff we're bonding on, and it seems to be staying on in full mouth reconstructions, is actually pretty amazing. And we're not the only ones doing it. Yes?
I want to make it clear what you just said. The white chalking pattern you see after etching porcelain is not desirable.
Yeah, it's not desirable. That's exactly right. So the way to get it off, the easiest way, is with just phosphoric acid, the stuff you use to etch in the mouth. 30 seconds, put it on there, and then just rinse it off. That's it? Yes, sir.
So if I could summarize, if we are cutting an access through a zirconia crown, the best thing to do is to replace the crown. rather than restore it. Is that right?
I was being a little bit facetious about that, but I would say if it was in my mouth, I would say yes. But you have to be, I mean, just talk to your referrals about it gently, because yeah.
So if we can't bond to it, then is amalgam preferred if we're going to be restoring those accesses?
Actually, I don't have a good answer for that. I think it's you can't bond, and amalgam's going to leak anyway. I mean, I don't know whether the corrosion products will seal it. I don't have a good answer for you. But I don't have a high level of confidence that what anyone is doing, I mean, including if I tried to do it, would actually seal it. I mean, so. I mean, why don't you guys try it, and after a while put some stain in it, some methylene blue or something, and rinse it off and see whether you see a nice blue circle on there. And then you'll know whether it's leaking. But my guess is it's going to leak. Only because, you can't, yeah?
When you see the ones that have been on for a number of years, usually they're stained rough.
Yeah, yeah.
I don't see many of them. In fact, I can't remember seeing any of them that fractured, but I've definitely seen them with
the leakage, yeah, yeah. I mean, like I said, I can't speak to that because I don't really do too many of those things myself. And when we do them, we get the endo done before we put those things on, not the other way around. So we give you guys a bit easier time. Yeah.
Oh, when you do an endo access through a gold crown, what is your preference for the restoration?
Amalgam. I mean, because, it's metallic, the patient's not going to complain. But if you put a zirconia crown, then you put the metallic restoration in there, I don't think they're going to like that. So, it's 4 o'clock right now. I didn't take any of your time.